Bigger chair. Good afternoon all. I thank Dr. Nagarjuna and organizing committee for giving me this opportunity to interact all the pulmonologists. For many years we worked close by in the same endoscopy unit doing EES procedures and EBUS procedures. So when it comes to role of EES, FNA, and now we are moving on to FNB mainly, it has certain advantages compared to EES. You heard quite a lot about EES complications, minimizing the complications and taking care to get the better tissue. So a couple of things is, it is minimally invasive. EBUS is minimally invasive, EES is even more minimally invasive. And there is an improved imaging quality, tremendous improvement compared to 10-15 years ago, and we are moving into the new imaging processor you watched yesterday. And the depth of examination will be up to 10 centimeters for us. The optimum depth will be from 6 mm to 6 centimeters. So we got quite a wide range of view, and wider area of examination is there, and very minimal side effects. The main side effects we worry is bleeding. In your airways, bleeding is a major problem. In the GI tract, that is actually a minor issue with us. So fortunately, that's not a problem, and can be done under light sedation. At times we even do under throat spray also, but if it is just a subcarinal node, we can do it under throat spray in a cooperative patient. Otherwise, it requires light sedation. And contrast harmonic EUS and EUS elastography are added into the new machines, which will aid in improving the accuracy of the sampling. And we always have rows, fortunately, in most of the units to guide the adequate and targeted tissue sampling. So this is where we are using FNAC just to confirm that we are getting the sample from the targeted area before going on to take the FNB. And scope of EUS in pulmonology, so useful for mediastinal nodal FNAC and FNB, as we discussed over the last 2 days. Can be used for subcarinal node and left paratracheal node sampling when there is a significant respiratory distress. If you think that your patient is very unwell and you will require intubation and other things to get the sample, EUS is one of the alternative thing. And sometimes if they have dysphagia with only subcarinal nodes, then we do see the erosion into the TB lymph node eroding into the esophagus, presenting as a TB. We do not call it as a TB esophagus, but it is a subcarinal nodal TB. And in that situation, EUS would be the first option. It's also safer in high-risk groups. Tissue yield is very good with current set of needles, and also it complements. As you know that most of the modalities we discussed over the last 2 days will not give complete staging for CL lung, so EUS will be added to complement and improve the accuracy. Very rarely I came across few cases of large lung lesions eroding into the esophagus, where it was very easy to just go across the esophagus to get the sample. And lung cancer staging, as you all know, it needs proper, accurate staging for tailoring the best treatment for choosing between medical and surgical treatment. Now we have CE, CT, FDG, FET, but PET is a suboptimal investigation in certain cases and in certain stations. Mediastinoscopy is getting outdated. EBUS, TBNA will be inadequate for certain nodes, where the EUS will complement EBUS. Combined use of EUS and EBUS is shown to improve the accuracy, and a recent study from 2021 showed improvement in the sensitivity from 45 to 92% respectively to 68 to 100%, and more importantly, negative predictive value also increases to close to 100%. And I put one question there. EUS FNAC is feasible in lower mediastinal nodes, left lobe liver mets, celiac nodes, adrenal mets, hepatic hilar nodes, and all of the above. Dr. Pawan accidentally took the tissue from the spleen, but we can deliberately go and get the splenic hilar node if we want. So everybody agrees that we can reach further than EBUS. Moving on. So EUS can reach mainly lymph node stations as we discussed, and also retroperitoneal nodes we can target. Intra-abdominal nodes, which are the point of interest is hilar nodes and also the celiac nodes. Periportal nodes are seen in tuberculosis patients like we demonstrated yesterday. And if there is a liver met, we can target and take liver biopsy. Now we started doing liver biopsy for a couple of years with EUS with no increase in the complications. And 2 or 4 nodes can be rarely targeted with these things. Aortopulmonary window is still a challenging space, which is still difficult with EUS also. So the area represented in the block is your territory. The area represented in the striated nodes are our territory, and the overlapping one is the 7th station. And then just I added this one. So adrenal gland, sometimes it is the commonest site for the incidentaloma in the routine screening. And if our patient who has no other nodes and lung cancer, there is a dilemma whether it is a true malignancy or just an incidentaloma. That's where this elastography might help. So you can see that this is a big node, and then when we apply the elastography, and this is a histogram, the softer part is 0 to 255. The pale blue part one is the softer one, and then that is the red one is the harder parts. And in the picture you can see in the histogram as well as the one which was shown similarly by previous speaker, the blue area suggests that this is a malignant node and that should be targeted. And one of the few things is the stations in the EUS are fixed. If you want to do a quick subcarinal node sampling, it is always located at 25 to 26 centimeters. You can pass the scope up to 26 centimeters and look up anteriorly, and the node will be there. But the G junction is variable. Most 80% of people's G junction in females will be around 37 centimeters, in males will be 38 to 39 centimeters. Tall 6-footers will have 40 to 41 centimeters. So one can go up to the lower part and come over there. So these are the fixed landmarks. So one need to remember 38 to 48 centimeters for the G junction for station 8 and 9, 25 to 26 for subcarinal region, and slightly proximal is AP window. So can we play this one, please? Just click on. So here we are starting. Yesterday we demonstrated this, Dr. Pawan nicely demonstrated even with the EBUS scope. Can you play it? So we are starting from the G junction, and after examination of the left lobe of the liver, we move forward, backwards into the esophagus, and we focus it on the aorta in the completely anti-clockwise direction, and then rotate the scope to the clockwise direction. So until you get the aorta. So you will be covering the 360 degrees, and then we have to do that every 2 centimeters until we reach 25 centimeters. That's how we pick up all the things. So compared to all the other imaging, you see the EUS imaging of the left atrium, you see the pulmonary, you can diagnose the vegetations and everything through, you can do a simply transesophageal echocardiogram with our EUS scope, and left atrium is the marker, so quickly identify the left atrium, and then we go up to move on to the next station. So in between the left atrium pulmonary veins up to the G junction are the lymph node stations for 8 and 9. Play that one, sir. So to reach the station 7 with EUS scope, we again focus on the left atrium, and then you can see the aorta, and then pulmonary artery will come into the focus as we withdraw slightly, and then with slight adjustment and rotation, we can bring in the subcarinal nodal group. In this case, there are multiple nodes. And you can appreciate the depth of the EUS imaging. It's marked around 10 centimeters over there. So now clearly the arrow is pointing towards the pulmonary artery, and above that you can see multiple lobulated lymph nodes with loss of hilum and slight heterogeneity. So this can be targeted for therapeutic purposes. Next one. So coming to the technique, we have slight advantage. We have the elevator with the EBUS scope. So the fanning of the fanning technique to obtain samples from all parts of the lymph node is slightly easier, but you can also achieve with EBUS. But this is to just demonstrate the fanning technique used by us. We take the needle all the way up to the edge of the lesion and then rotate. So that's how we need to obtain the proper tissue. And yesterday we were demonstrating this one for the beginners. So if somebody has, I tend to ask them, do you have any difficulty swallowing the capsules, tablets, big tablets? If they have difficulty swallowing those things, and rheumatoid patients and also previous history of webs, one need to be careful when introducing the rigid scopes. And these are the two ways of converting your scope to inflate the esophagus. I think that's the end of my talk.